Good morning. My name is Karina Siracusa, and I am the workshop chair for this workshop this morning. Welcome to all of you, and welcome to lovely Florence. Today we're going to be talking about pelvic floor physiotherapy for the client with neurologic dysfunction. So just to tell you a little bit about myself, I am a physiotherapist from the United States. I work in the Midwest in Ohio for a large hospital system. I am the head of our neuroincontinence center there, so I see all of our patients that are being treated for regular neurophysiotherapy for bowel and bladder dysfunction, and that's some of what I'm going to talk to you guys about today. I also sit on the board for the section on women's health of the American Physical Therapy Association, and I am an instructor for the American Physiotherapy Association for our people who are physiotherapists who want to learn how to be trained pelvic floor therapists. So we'll just get our presentation up here. In the meantime, while we get that up, let me introduce Lori Mize, who is my fellow co-speaker, and I'll let her introduce herself. Go ahead.
Okay. Good morning. I'm Lori Mize, and I am also a board member on the Section on Women's Health board as the Director of Education and an instructor in pelvic health, and I am an assistant professor at Lynchburg College, and I'll be speaking to you in just a few minutes.
So just a few housekeeping things. Both Lori and I obviously are members and board members of the Section on Women's Health for the American Physical Therapy Association. We wanted to remind you to make sure that you complete the in-app workshop evaluation at the end of this workshop. You'll see on the slide here, you go into program by day and pick our workshop. And then you will scroll down and you will see that there's a place to do your evaluation. And please give us feedback as to what you thought of the presentation. There's a short survey on there. There's a shortened version of our handout that has been provided at the entrance hall. A full handout for all workshops will be available via the ICS website. Please remember to silence your mobile phones, and please refrain from taking video and pictures of the speakers. There will be video and pictures that are available after the conference. Just to get a little sense of the room, how many people in this room are physiotherapists? Good. How many are nurses? Good. Great. And physicians? Wonderful. So we really tried to, we only have 60 minutes, which is a short time to talk about such a huge topic. So we really tried to make this applicable to everybody in the audience. Please, though, at the end, we are going to leave time for questions, so please feel free to ask questions as we go along, okay? All right, I'm going to hand it over to Lori to do the introduction.
Thank you, Karina. So as a whole, when we speak about neurorehabilitation, it's very interesting to think about how we have many patients who have neurologic dysfunction, who have several functional losses and significant dysfunction, and oftentimes bowel and bladder issues become very low on the totem pole, so to speak, whenever it comes to rehabilitation. It seems like the other issues with mobility and quality of life seem to take a little bit more precedence. And so, they have a variety of needs. Patients in this population. They are being treated by multiple specialists, that being physicians, therapists, etc. And so the typical diagnoses that you will see, that we will see in neurologic physiotherapy would be cerebrovascular accident, or CVA, spinal cord injury, ALS. We will see Parkinson's disease, multiple sclerosis, and also occasionally concussion. We'll have some issues when it comes to pelvic health physiotherapy. So just briefly, the neuroanatomy, I know this will be quite the review for most of you in the room. So when it comes to micturition, in normal micturition processes, we want to see intact neural control, adequate detrusor function, absence of obstruction, and pelvic floor muscle relaxation that occurs with voiding. When there's micturition dysfunction, there may be non-relaxing pelvic floor muscles, or there may be poor or absent detrusor contraction or mechanical obstruction. Oops, I'm losing earrings. I'm getting so fired up about pelvic floor physiotherapy, I'll just take them both out. So this infographic just shows a little bit about some of the normal values for micturition. So we have a 400 to 600 milliliter, give or take, bladder capacity, typically, and it takes about 1 to 14 millimeters per minute of renal input into the bladder when it's filling. Voiding will occur 4 to 8 times per day whenever it's considered normal. And then typically at about 40% of capacity is your first sensation to void. At 60% of your bladder capacity, it produces more of a desire to void. And then at 90% of this capacity, you have a strong desire and urge to void. So we'll talk briefly about bladder issues in the patient with neurologic dysfunction and looking at some of those specific diagnoses that I mentioned. So specifically for bladder complications in CVA, there's a disruption that can occur in the neuromicturition pathways, especially in the area of the pontine micturition center. And so patients who have suffered a stroke will have related movement dysfunction, also cognitive and language deficits, but they may have normal bladder function. However, these movement deficits and cognitive and language deficits can prevent them from being able to get to the bathroom on time or effectively, and can thus produce bladder dysfunction in and of itself. Concurrent neuropathy or medication use. So we're thinking about, these patients who are on oral Lasix, who have now increased voiding frequency and urgency as a result, and could have increases in incontinence. And also the neuropathy that can occur with things like type 2 diabetes. And so I see that in patients who have significant neuropathy. They have a significant decrease in their pelvic floor function and coordination and communication as well for proprioception. And then also in this population, it's more common to see neurogenic detrusor overactivity. And typically urinary retention is commonly reported very early on in patients who have experienced a CVA. So I think this statistic is actually pretty astounding. Between 40 to 60% of patients with CVA experience incontinence. And really the reason why we're giving this talk this morning is because we feel like this is an area of pelvic health and physiotherapy that is very underserved. Again, like I mentioned before, some of the other issues that go along with CVA seem to take more precedence, but we see from Thomas that 40 to 60% experience incontinence. And so it's really something that I think that we need to do better with screening, and also just keeping in mind those quality of life issues and from any healthcare professional, both physicians, healthcare practitioners that are primary practitioners, and physiotherapists alike. And so let's talk about multiple sclerosis and some of the bladder complications that can occur in this particular neurologic condition. So neurogenic detrusor activity can also occur in MS, or detrusor sphincter dyssynergia. Weakness of pelvic floor contraction is typically seen in this population, and also you may see spasticity of the pelvic floor muscles as a result. So again, it's important to have a very thorough examination as a pelvic health physiotherapist in order to see which type of these conditions are occurring. And these patients are most likely to report bother from overactive bladder symptoms, which I find is typically what we will see in the clinic. Some other complications include urinary incontinence in patients with urinary urgency frequency symptoms. So like I mentioned, this seems to be the primary thing that I see clinically whenever it comes to this patient population. Typically, patients with multiple sclerosis wait an average of 6.5 years before they report bladder symptoms. So this supports the statistic that I mentioned before in the CVA population. This is an area that is a significant quality of life impact on these patients, but they wait a significant amount of time before discussing these issues with their healthcare practitioners. So overactive bladder can also be associated in this population with significant depression and low self-esteem, as well as reduced quality of life. So when it comes to pelvic floor muscle training for the patient with multiple sclerosis, there are some disadvantages, and there are some considerations that we have to have in this particular population. When it comes to overworking the muscle and over-fatiguing the muscle, this can be an issue in patients with multiple sclerosis. So you may see an increase in voiding dysfunction if those pelvic floor muscles are overtrained and overworked. They could have decrease in their ability to relax their pelvic floor muscles. And this can also result in urinary hesitancy or intermittence of the urine stream, and also high post-void residual volumes and retention symptoms. So for spinal cord injury, bladder function definitely depends on the level upon which the injury has occurred. And bladder function is largely influenced by the S2, 3, and 4 sacral nerve roots. So an injury above this level is definitely going to produce bladder dysfunction in this population. And so incomplete versus complete spinal cord injury affects the ability to have recovery when it comes to bowel and bladder function. Even in patients who have a spinal cord injury such as transverse myelitis, and it produces more of an incomplete type spinal cord injury, will present with various bowel and bladder dysfunction, retention, they have to self-catheterize, etc. So with spinal cord injury, early in rehabilitation, patients typically catheterize, self-cath, every 4 hours. And then as sensation is gained, their bladder schedule may change. And so bladder function does tend to worsen in patients as they age, if they have spinal cord injury, and typically medications that are generally utilized are anticholinergics and Botox injections into the bladder. I think about my patient with transverse myelitis in this particular category, because this patient was coming in, he had to self-catheterize, and he wanted to live he was a missionary out in the mission field, and he was unable to find a clean, sterile environment to perform his catheterizations while out in the mission field. So we were able to work through with him with his voiding dysfunction, behavioral interventions and such, and get it to where he was cathing in the morning and at night, and that was an appropriate emptying of his bladder throughout the day. So he was able to return to the mission field, and that's a nice example of an incomplete spinal cord injury as a result of that condition. So just again, brief overview, because this is a very, very quick covered topic. We're going to talk about general physiotherapy interventions in the patient with neurologic dysfunction. So Karina uses this 5-question screening tool, which is really more of an adaptation to the 3 incontinence questions that you'll see as a screening tool. And we feel like this is really effective and helpful in patients who have neurologic dysfunction. Because, in order to identify some of these issues that may be unaddressed or overlooked in this population, you need to ask some of these questions as a primary care provider or as a physical therapist that may not necessarily be a pelvic health physiotherapist. So the questions includes, number 1, do you ever leak urine or feces? And number 2, when you get the urge to urinate or defecate, can you delay it? And if so, for how long? And then number 3, when you sit down to go to the bathroom, do you have trouble initiating urination or defecation? And number 4, do you feel like you fully empty your bladder and bowel? And number 5, do you have pain associated with urination or defecation? So these particular slides really address, issues of incontinence, but are also asking questions to try to screen for retention and also pain. So answering yes to any of these questions should trigger a referral to a pelvic floor physiotherapist. And keep in mind that even if these bowel or bladder issues presented before the neurologic insult, patients would still benefit from a referral to physiotherapy for these conditions, and they can still have significant changes in their quality of life as a result of these interventions. So for a physiotherapy evaluation in the patient with neurologic dysfunction, behavioral assessment is critical, and that's one of the primary areas of intervention for this population when we see these patients. So really looking at, their toileting habits and drinking habits, and how do they move, and how can they get to the restroom, and all of these different things. Their bladder diary is very important to analyze those habits. It's very important to perform a neurologic exam in and around the perineal area, looking at anal wink, the bulbar cavernosus reflex, and also looking at knee and ankle reflexes for the S2, 3, and 4 areas, and to kind of see if there's also lumbar involvement as well, depending on the type of neurologic dysfunction. These patients may or may not have an internal pelvic floor muscle examination. It may be appropriate, it may not, especially if these patients are found to have more behavioral intervention needs. And then intervention for neurogenic lower urinary tract dysfunction. So typically, interventions are generally chosen based on whether there's a failure to store or a failure to empty. And the goals in treating this patient population is to keep bladder pressure low, to avoid reflux and upper urinary tract damage, and also to avoid elevated post-void residual. And so therapies to facilitate urine storage related to the sphincters include electrical stimulation and biofeedback. So I have really found that electrical stimulation, whether we're talking about the use of TENS externally for urgency, also for retention, it's very effective in this population. The use of intravaginal neuromuscular electric stimulation to increase neuromotor recruitment in patients who have some level of decreased proprioception as a result of neuropathy can be helpful if sensation is appropriate and present. And biofeedback is also helpful in this population, especially when you're trying to help them see and detect very small changes that occur whenever they contract their pelvic floor muscles. You can do pelvic floor muscle training without biofeedback. Typically, that's what I do in my practice, is more pelvic floor muscle training without biofeedback, but it can be helpful to use biofeedback with this population. There are other vaginal, perineal, urethral occlusive or supportive devices. Pessaries can be very helpful in this population to be able to give support and also to be able to help occlude the urethra. Collagen injections and also surgeries can be effective in treating this population. And now Karina is going to come and speak to you guys about evidence for physiotherapy interventions.
First, did you have a question about the 5 questions?
Yes, how is pain associated with neurological bowel and bladder?
So the question is, how is pain associated with neurologic bowel and bladder dysfunction? What I will typically see in my patients that have an upregulated pelvic floor or spasticity in the pelvic floor, they may actually have significant pain with urination or defecation because they can't relax the pelvic floor. And so then what happens is they do a lot of straining for both bowel and bladder. We'll see a lot of patients that are pushing on their bladders in an effort to really expel all the urine, and that can lead to a significant amount of pain. The other thing with that 5 questions that I tried to address was that I'm also looking, those questions are being asked by neurologic physiotherapists. So physiotherapists that maybe aren't as comfortable talking about some of these bowel and bladder issues. So I wanted to give them something so basic that if the patient said yes, leave the rest to me, so this way I can kind of evaluate what the critical nature of their bowel and bladder dysfunction was. But that's a very good question. So there is quite a bit of evidence for treating this population, and as Lori said, it's very frustrating because I don't think that we're screening effectively in this population because there are so many other medical concerns that are going on. We're also not educating our patients enough that there is help out there for some of these conditions. I can't tell you how many patients have come into my clinic that have said, well, I was incontinent a little bit before. Yes, it got worse after my stroke, but I didn't think that there was anything that I could do about it. I thought, well, I had a stroke. I'm going to have to wear Depends for the rest of my life. That's just the way it is. And that's simply not true. Same thing with my patients with MS. They will tell me all the time, oh, well, you know, I heard that incontinence and urgency frequency is just a part of MS and that I have to live with this for the rest of my life, which is simply not true. There are so many patients that with very, very simple pelvic floor interventions can be helped. So we're going to talk a little bit about the evidence to start. And I'm just going to highlight, there are many articles out there. I'm going to highlight a few of them that I generally will present when I'm talking to physicians, especially about the need for pelvic floor therapy. So this was a study done in 2014 in patients with CVAs. They used TENS, suprapubic TENS, combined with traditional pelvic floor muscle therapy. So one group had just the regular pelvic floor muscle therapy, meaning mostly exercises, Kegels, core stabilization, and then the other group, they added suprapubic TENS. Both groups had improvements in incontinence. However, suprapubic TENS plus exercise actually had the greatest impact on incontinence. And I have used this with several of my patients because a suprapubic TENS unit you can send home with the patient. It's something that they can easily do in order to get the greatest benefit at home, and you may not necessarily be using up physiotherapy visits. There was another study that looked at just general rehabilitation training, meaning general core stabilization exercises, nothing really focused on the pelvic floor, versus 50 minutes of pelvic floor muscle therapy, really targeting the pelvic floor, really targeting with Kegels. Obviously, the experimental group that received that targeted pelvic floor muscle exercise got a stronger pelvic floor. Anytime we really focus our energy on one type of exercise, we're going to have better results. However, and the lower urinary tract symptoms decreased in the patients that completed pelvic floor muscle therapy. As far as some studies in MS, there was a study that looked at pelvic floor muscle therapy as a quality of life indicator, and women that completed pelvic floor muscle energy had a huge increase in quality of life. I have some women that are afraid to leave the house because they have so much urgency and frequency that they're going many, many times a day. The worst case I ever had, I had a woman who was going to the bathroom 65 times a day when I looked at her bladder diary. She literally had not left the house in 3 months because anytime she walked out of the house, she had to go to the bathroom. That's a huge quality of life indicator. And with 4 sessions of physical therapy, she was better. She wasn't 100%, but she was better. So I often tell patients that a little bit goes a long way in this, and really making sure that these patients have the quality of life that they want. That oftentimes, especially in MS, the disease takes so much independence away from them as it is. If we as pelvic floor physios can give them back a little bit of independence, that's huge for these patients. There was another study that was a randomized controlled trial that showed that patients had increased activity levels after pelvic floor muscle therapy, meaning they were able to activate and access their pelvic floor after that targeted pelvic floor muscle therapy. It's not okay, it's not good enough to just hand them a sheet of paper that says do some Kegels on it. You really have to target it and individually tailor that program to that patient. And then there was another study that showed that pelvic floor muscle therapy, those patients showed a significant improvement in urinary urgency, urinary frequency, and overall incontinence. Now, this is an interesting study. This is a kind of a byproduct. So one of the disease-modifying therapies that you will often see patients with MS on is something called Tysabri. And for some reason, we're not really sure the mechanism. Patients that are on Tysabri have less bladder issues than patients that are on other disease-modifying therapies. So when I talk to pelvic floor physios especially, I always say you do have to talk to some of the neurologists about some of these disease-modifying therapies, because we're not sure all of the mechanisms of actions, but we do see byproducts. Lemtrada, on the other hand, which is another disease-modifying therapy for patients with MS, those patients have increased bladder complications. There is a new MS drug that's out on the market called Ocrevus that's in clinical trials. They're actually doing some clinical trials at my hospital, so I'm doing some concurrent research on what the bladder side effects are being. Thus far, we're seeing positive side effects. Patients are having improved bladder function that are getting the infusions of Ocrevus. So it's important to know what disease-modifying therapies they're doing, what they've tried, because it may have an impact on their bladder function. I tend to follow all of our MS patients long term, and I'm going to talk a little bit about that at the end when we talk to case studies. But we also see a big change in bladder function when they change disease-modifying therapies. So it's common for patients with MS to, one drug will stop working, and so they may switch them to another drug. And we've seen big changes in bladder when they switch disease-modifying therapies. So it's important to kind of have that in the back of your mind if this is a patient population that you're going to be treating. But again, Tysabri is one of those ones that the treatment effect tends to remain over time, and these patients actually have less bladder complications than patients that are on other disease-modifying therapies. There's another study that looked at the randomized controlled trial. The experimental group received 48 sessions of pelvic floor muscle therapy, which is a lot of physiotherapy, 2 times a week, and they did exercise and internal electrical stimulation. The control group received just home instructions. Both groups improved, but the individual treatment had better results. So we always say doing something is better than doing nothing. I would rather at least have patients get some education about bowel and bladder function and get some education about pelvic floor muscle therapy, but ideally I would really like to see them in the clinic. I really want to be able to feel what their pelvic floor is doing in order to be able to prescribe the best exercise program for them. Another study looked at pelvic floor muscle therapy using EMG and sham electrical stimulation. Group 2 had the EMG and intravaginal e-stim. Both groups improved, but the pelvic floor muscle therapy and with electrical stimulation had the largest improvement in the patients with MS. There is some evidence in spinal cord injury, and this is another important one because I feel that, again, a lot of times people say, oh, well, I had a spinal cord injury, I'm just going to have to cath. That's fine. We're just going to, this is my life now. There's not going to be any improvement. And that's simply not true. The other big thing that I want to point out before I really get into the research for spinal cord injury is that I tend to see patients, they get discharged from inpatient rehab with one bladder kind of plan and one cathing schedule, and then they don't go see a urologist for 2 to 3 years after that. And so they're not getting updated on their plan. They're not getting any sort of checks on their post-void residuals because they've got all of these other doctor's appointments that they're going to, and urology for some reason seems to be very low on the list. And so I am constantly checking in and saying, hey, have you made that appointment with your urologist yet? Have you followed up with your urologist? Because physical medicine doesn't always do a great job of getting these patients to the appropriate practitioners. So it's really important to really kind of take a look at that. And again, educate your neurophysio colleagues that ask them about their bowel and bladder dysfunction, ask them if they've seen a urologist since their injury, and if they've had a checkup on their cathing schedule. So this study was done in 2015. It was only 2 patients, so it was just a case control. They had one patient with an ASIA C and one patient with an ASIA D, so we're talking incomplete injuries. They were giving a 6-week program of pelvic floor muscle therapy. One of the patients improved the ability to increase detrusor pressure and had improved continence, so they were able to actually urinate on their own and push more urine out on their own rather than just cathing. And the second patient had a small reduction in overactivity but no change in continence. So they weren't having the urgency frequency, which can still be a huge improvement in quality of life if they're not having that autonomic dysreflexia feeling. The other thing that some places are looking at is sacral modulation in spinal cord injury, mainly with incomplete. The study had patients that had an interstim. 14 patients had an improvement in continence and detrusor overactivity, but more patients had an improvement in quality of life. So again, we may not always see in some of these research studies that their numbers are changing, but if they can have an improvement in quality of life, that's huge. And to the patient often, they don't care that maybe their post-void residual is not as bad as it was, but if they can go out for longer and spend more time out in the community, that's what they care about. So, there really is a reason for us to be doing pelvic floor muscle therapy. Some of the specific PT interventions. So with CVA, I do a lot of timed voiding with these patients. As Lori mentioned, when they have a CVA, often we're working with patients with hemiplegia. So they have decreased mobility, decreased fine motor ability. They can't get their pants down as quickly. They can't get to the bathroom when they have that urge as quickly. So it's not necessarily bladder dysfunction that's causing their incontinence. It's the fact that they're not able to reach the restroom on time, or they're not able to, because of the neuropathy after their CVA, they're not getting that same sort of bladder feeling, that urgency, and so they're waiting much too long to go to the bathroom. So timed voiding works great with this population, saying, all right, instead of relying just on your urge, let's have you go at specific timed intervals. This is also a huge burden lifted off of caregivers, because then they're not trying to rush those patients to the bathroom. They're saying, okay, we're going to go at 10 o'clock, we're going to go at 12 o'clock, we're going to go at 2 o'clock. It's a much easier on the caregivers to be able to follow a bladder program like that. We usually work on core strengthening exercises, making sure that they have a proper assistive device, again, so that they can make it to the bathroom on time. I may look with their neurotherapist, and can they get that walker into the bathroom? That's another thing that I see. If they have some of these huge assistive devices, they may not be able to access their bathroom, or they're kind of furniture wall surfing to get into the bathroom, which delays them even more. So what can we do to make sure that they are able to reach the toilet on time? And then if we can, prescribing them Kegel exercises. However, what I find in the CVA population is that often they have such poor proprioception because of the hemiplegia, they can't feel that side of their pelvic floor. It's interesting when you do an internal exam on a patient with hemiplegia, because you will feel their intact side contract, and then you will go over to the other side of the levator ani and you will feel nothing when they attempt to contract. We can't train just one side of the levator ani. We can't tell you, okay, just contract the left side. So I wish we could. It would make things a lot easier. So what are we going to do? Are we going to do some hip exercises to try and activate that left side a little bit more? Are we going to really focus on e-stim to try and intravaginal e-stim to try and get them some more proprioception on that side, to feel it contracting, and to get the e-stim to contract that side a little bit more? So, thinking about some of those things, thinking about their overall physical functioning, will then help you treat their pelvic floor. You just have to be a little bit more creative sometimes with these patients. You can't, as I said, you can't give them a handout and say, all right, just do 10 squeezes 10 times a day. In the MS population, we see about every year we see about 300 new MS patients at our clinic, and in addition to the ones I'm already following. And so every single one of those patients gets a consultation with a pelvic floor physio. Every single one. I'm very busy. So what we do is we do a bladder diary with them, and we look at, okay, what are your main problems? What I tend to see with the MS patients is that it's either that they can't initiate that flow of urine, and so that's where I use the suprapubic vibration. It works really, really well. And you don't need a fancy vibrator. You can usually go to the drugstore. I had one patient that actually found her grandson's teething toy, where you press on it and it vibrates, and she kept that in her purse because she said it made her feel less self-conscious that she just had her grandson's toy in her purse. But she would put that over her bladder suprapubically every time it was time for her to use the restroom, and that helped her detrusor to contract. Neuromodulations. I'm seeing InterStim a lot more with my young patients with MS. So I have a patient right now who is a 26-year-old OBGYN resident, and she has really horrible fecal incontinence as a result of her MS. And so we tried kind of the traditional conservative routes. It wasn't working. We did InterStim. It was hard to convince her neurologist to do that, because now MRIs are something that they do consistently to look at progression of MS, and now she can't have an MRI because of her InterStim. But for her, from a quality of life standpoint, she told me, I can't be in the middle of delivering a baby and poop my pants. It's not, I can't poop at the same time mom's pooping. So she said, this was a quality of life and a job thing for her, so we chose to do it. Behavioral techniques work great with this population. A lot of women with MS have that urgency frequency syndrome and that incontinence because they're afraid, or urgency frequency because they're afraid to leak. And so what happens is that they go to the bathroom every time they have that first desire to void at that 20 to 40% of bladder capacity. And so then it just gets worse and worse and worse. So talking to them about, a lot of times I'll say, well, have you ever actually leaked? Well, no, but it feels like I'm going to. So teaching them that they don't necessarily have to go every time they have that desire. Fluid and fiber management is another big one with this population. They will stop drinking water because they think if they stop drinking water, they won't urinate. And so I had the patient in a case that I'm going to show you guys. She was drinking less than 6 ounces of water a day because she didn't want to urinate that often. So educating them about fluid and fiber management and constipation management. And then pelvic floor muscle exercise. As Lori mentioned, though, the biggest factor with MS is fatigue. These patients get over-fatigued very easily. So with this population, you're not going to prescribe them the same endurance holds and the same number of repetitions that you are going to prescribe a patient without MS. You're going to prescribe much lower repetitions and lower endurance, but more frequently throughout the day in an effort to keep the pelvic floor muscles from fatiguing. With spinal cord injury, I'm going to look at the level of spinal cord injury. I'm going to evaluate sensation. Are they relying on some of those signs of autonomic dysreflexia? So I have a patient right now that just tells me, yeah, when I get sweaty, I know it's time to go calf. So what are they doing for their bladder sensation? I want them obviously to have urodynamics, so anytime I have a patient with a spinal cord injury that has not seen a urologist, that's the first thing. Before I do any sort of intervention, you need to go to a urologist, you need to have updated urodynamic testing so we know what your bladder is doing. Looking at their catheterization schedule, are they cathing too often? Are they cathing not often enough? Looking at bladder diaries. If it's an incomplete injury, I may do some biofeedback in order to evaluate their proprioception. And sexual functioning. Don't forget about sexual functioning with these folks. A lot of them don't know who to ask about sexual functioning, both male and female. So erectile dysfunction with males and anorgasmia and general lack of lubrication with my female patients. It's, again, a huge quality of life indicator, so making sure that we're asking about that. So really quickly, I'm going to go through just a couple of case studies of patients of mine. I want to make sure we leave time for questions. So with this first patient, he had cauda equina. So he was an incomplete spinal cord injury, and I skipped ahead. This patient was a CVA patient. So she was seen by her neurophysical therapist. She was a relatively high-functioning CVA patient, meaning she was pretty mobile. She had some strength deficits after her CVA, but it was not, it was a fairly mild CVA. She had some hemiplegia. And so she was being seen by her neuro PT for improvement of mobility and strength in her lower extremities. However, after about 2 sessions, the patient said to her neurophysical therapist, "I've got some strange symptoms. Can I tell you about them?" And the neuro PT, who happened to be a good friend of mine, so she's used to hearing about bowel, bladder, and sexual functioning in general conversation, said, "Yeah, sure, what's up?" She said, "Well, ever since my stroke, I woke up in the hospital and I feel real good with the world." And she said, "Well, what do you mean by that?" She said, "I am aroused all of the time. And masturbation is not helping," and she said, "Nothing takes it away. I can have an orgasm, but I'm still aroused." So she had persistent arousal syndrome. During the PT eval, what I looked at, she had superficial pelvic floor weakness. She had decreased sensation at her dermatomes, no evidence of prolapse, but her levator ani had so much spasticity in it that is what was causing that sensation of arousal, was that she basically had a constant pelvic floor contraction. So with her, we did some manual therapy to the pelvic floor and some down training, some relaxation down training, 3 sessions, and it was completely gone. But the important thing with that case that I want to point out was she had not reported any of that to any of her physicians because she didn't feel comfortable talking to her physician about it, but she felt comfortable talking to her neurophysical therapist, who has no pelvic floor training whatsoever. And she just said, "Is that normal? Have you ever heard of anything like that?" And she said, "Well, I think I haven't, but I think I have the person who has heard of that. So, let me send you to the pelvic floor therapist." So my second case is my cauda equina patient. So the initial concerns with this gentleman was that his bowel and bladder issues were interfering with his standard physical therapy. He was coming into the clinic, getting in, going straight to the bathroom, spending the first 20 to 30 minutes of his neuro PT appointment in the bathroom. And so by the time he would come out, they would not have much time left to treat. So they came to me and said, "Hey, we need to figure out what's going on. Why is he in the bathroom for 30 minutes every time?" So he had a lot of constipation, and that's what was going on. He would get the urge to defecate. He would feel like he had to go. He would also get the urge to urinate, and then he would sit there and he wouldn't do anything. But he would sit there for 30 minutes attempting to urinate and defecate during his sessions. For this particular patient, bowel and bladder were some of the first signs of his initial nerve compression injury. He was on a bowel and bladder program. He had a bowel and bladder program that he was discharged from inpatient with. His current bowel and bladder program, for the bladder, he was on several medications. He was restricting his fluids. He was not drinking hardly anything at all in an effort to not be incontinent. And occasionally he was catheterizing for some post-void residual, but it was not, this one was one where he was not listening to physician recommendations. He was cathing when he felt like it, and was not doing it consistently enough. For his bowel, all he was doing for his severe constipation was taking Metamucil. He, on average, was having a bowel movement once every 14 days, which was causing a lot of his incontinence problems because he was so full of stool. However, the problem with this gentleman was due to his insurance. He had very few PT visits. So we were only getting 4 PT visits that were authorized at a time. And then what would happen was we would reapply to his insurance company and they would only approve, they would take 3 weeks to approve 4 more visits. So there was these big gaps in his continuity of care. So what we decided to do with that was I was just going to do a consult basis. So I would essentially come in and talk to him about bowel and bladder issues while he was being treated by neuro PT. So when they were walking him in on the treadmill, I was talking to him about bowel and bladder. Luckily, he was okay with talking about it in front of everybody else in the gym. But we talked about fiber management. We talked about what he could do in an effort to try and relax that pelvic floor a little bit more so that he could have better urination and defecation. Again, his fiber management, he had less than 10 grams of fiber per day, and I did just external palpation, and he was not relaxing at the time of the initial evaluation. So we worked on that relaxation. He was very resistant to change. He was one of these guys who had not the best diet and was very resistant to adding any fiber and water into his diet. But with encouragement, he did begin to change his bathroom habits, and within a few weeks he was not taking up most of his neurotherapy sessions sitting in the restroom. The other thing I counseled him a lot on was if you don't go right away, sitting on the toilet for 30 minutes is not helping you. So if you can't go within the first 10 minutes, kind of moving on. And then my last case really quickly is somebody that I saw with MS. She had been diagnosed with MS about 10 years prior, but she had a recent onset of urgency frequency. So she had a relatively stable bladder for the majority of her diagnosis, but she had just gone through a flare, a relapse, and so all of a sudden started to get these bladder issues. She was reporting mixed urinary incontinence, so she had both stress and urge urinary incontinence, no issues with constipation, and no issues with fecal incontinence. Her bladder diary really revealed that she was drinking less than 10 ounces of water per day because she thought if she didn't drink anything, she would not have to use the restroom. And then she was going to the bathroom all of the time just in case. So she would think that she was going to leak. And when I looked at her bladder diary, she was going to the bathroom about 22 times a day because anytime she got the urge, she would go in an effort to head off her leaking. She had no spasticity noted in her pelvic floor muscles. She had an okay contraction, but not good endurance. And she said frequently she felt like she wasn't going to make it to the restroom. It was really that true urgency incontinence. So for her, so I saw her for the evaluation. We looked at all of this. I made some recommendations based on her bladder diary. She came back the next visit, and it was funny because they have the urology residents spend a day with me to kind of see what pelvic floor therapy does. And so this was visit 2. All of her symptoms were resolved with just suggestions about pelvic floor exercise, fluid management, and not just in case voiding. And the urology resident looked at me and said, "Are they all this easy?" I was like, "No." I just made myself look good with just this patient that I was able to cure in 2 visits. So I include this case though because it was such a profound improvement with some very, very easy recommendations. So not every neuro patient has to come and see me for 40 visits. They can sometimes see me for 2 or 3 visits and make those recommendations, and that can improve them. So again, just counseling on increased fluid intake, decreased just in case voiding, and then we tried to increase her endurance. I did see her one more time after that, about a month later, just to make sure that everything was still going well, and it was. And we set her up on a program, and she has now she will see me just once a year because that's what our neurologists like us to do. She also improved her nocturia. So she had a lot of extra nighttime voiding and no incontinent episodes after just that 2 weeks. So now I left us some time for questions. Yes, so I'll have you guys stand up if you can and just, yes. Yeah, maybe I think the microphones are working. Sorry.
Have them introduce the country.
Yeah, she said. Oh, nope, it's not on. Sorry. Perfect.
Any improvement?
Yeah.
So, my name is Valpuri. I come from Finland. I'm a physiotherapist. I take a risk and dare to say that there are some, I think you agree, some cases of misdiagnosis of constipation, and that is because of the dysfunction of puborectal muscle.
Absolutely, I would agree with you. So, I do see that a lot of times where they have a non-relaxing pelvic floor, and so they think they have constipation. So with those patients, I have them really look at the Bristol stool chart and tell me what does your feces look like, and it's not, they have normal, fecal consistency, but they can't relax that pelvic floor. So I would agree with you that is sometimes misdiagnosed.
That's true, and I have become to use a lot of ultrasound with the convex probe and do the biofeedback exercises with that, because they don't know how to relax. It is a
Absolutely. Yeah, and ultrasound is another one that we're seeing more and more as far as helping to relax that pelvic floor and biofeedback.
That's true. Then I had another quick question or remark that it's again a big topic within a huge topic, the Botox and the uses of Botox within some symptoms that overactively contracts the bladder surroundings. I've got some with dystonia, so that helps that because they don't have any idea how full is the bladder at times, so they have to go to the toilet by clock, so every 2 or 3 hours. But when they are, can we say, high of Botox, then they know, okay, there's some kind of a contractions that, okay, I might have to go to the toilet or to cath or something like that. But, it's 4 to 6 months maybe period to have it.
Yeah, and that's generally what I see. I'm having really good success with intravesical Botox in my spinal cord injury patients. They're seeing much better quality of life and improvement in their bladder function with the Botox.
There's a prolapse of this microphone, so
sorry.
Thank you.
Thank you.
Thank you. Celia Bolton from Australia. I noticed you were using suprapubic TENS. Could you just comment on the parameters that you would usually use for that?
Yeah, so with the suprapubic TENS, we're using more of the interferential current for that, so the 80 to 150 megahertz. I generally do 20 minutes for the suprapubic TENS, and I cycle it. I do a 1-to-1 ratio, so 5 seconds on, 5 seconds off. And that really does help, just once a day, 20 minutes. And then I have them increase it to where they can feel it. I want it strong but comfortable is the parameters that I give them. You're welcome. Yeah, that microphone doesn't want to stay. There we go.
Hello, I'm Suzanne from Switzerland. I have a question. You talked about the study with 2 groups. The one we had 48 sessions, and the other one had just instructions for home exercising. And I wanted to know if you know the home instructed group, how were they instructed? Was it just verbally, or did they have palpation to learn how to contract their pelvic floor?
Yeah, it was just a paper. So it was just a paper. It was just a paper with some home instruction. Yeah, so there was no internal exam or palpation involved. Yeah, which is why I think
because that's a big difference.
That's a huge difference, and I think that's the biggest thing with the neuro population is that they can't feel their pelvic floor. So that internal palpation is really critical if you can. However, the one thing I will say is that I see a lot of pelvic floor physios that get worried about seeing the neuro patients because of mobility issues. If you have a spinal cord injury patient that's a dependent transfer, how do you get them up onto the table? How do you that's another big thing. So I was a pediatric therapist and a neurotherapist before I became a pelvic floor therapist, and I would see my adult patients with CP that hadn't had a urologic or a gynecologic evaluation in years simply because they can't get up onto a table. There's no tables that are accessible for them. So sometimes you have to be a little creative, but it's really important to be able to see that.
Thank you.
Thank you.
Marijke Slieker from the Netherlands. I popped in just a few minutes late.
is it possible that you didn't talk about Parkinson's disease, or did I miss it completely?
No, I did not talk about Parkinson's disease. Yeah, trying to cram.
Yeah, I
Now,
understand.
I will very briefly, I do see Parkinson's patients. We will see it's a lot of urgency, frequency, and then it's a lot of those mobility concerns. I see a lot with Parkinson's with also that hesitancy. So they have difficulty initiating the flow of urine. So the suprapubic vibration works really well with the Parkinson's patients.
I think that this must be the start for a big movement.
Yes.
Internationally. You know, we are busy also in the Netherlands with improving that. I will speak at the Parkinson's Congress for the first time. And it's a whole educational group. It's a community, and nobody ever talked about it. And we are all trained to be, what we say, bio, psychosocial, physical. We take the whole body, and we forget this part. So it is very good that we make a start of this. I'm reviewing your workshop, so I will try to push in the education committee that there's going to be more space for the neurological group, because it's huge. The neurology and the geriatrics, they both are very important. And the last remark, I think the neurological patients that we see and that I see, most of the times the pelvic floor is on a high tone.
Exactly.
Whatever you want to name it, hypertonicity, spasticity, short. We're going to discuss that on Thursday. But we see it even, in, for example, in patients with the Pompe's disease. They have core stability issues, and they are compensating with their pelvic floor, because it's the only way they don't fall in the bathroom. So we must try to find ways to get more balance in that pelvic floor. And I think you give a very nice overview that I would say is workshop 1, and it's the best kickoff we could have. So thank you very much for both your presentation.
Thank you very much. And I would agree with you too, from a spasticity standpoint. I mean, you feel true spasticity in the pelvic floor. And so, and again, we know how to treat that. We know how to, and so I am very passionate about it. It's why I've been trying to push this and push both pelvic floor physios to not be afraid to treat a neuro patient, and also to really try and get more awareness that we can help these patients and to get the referrals.
So your colleague said about there is 6.4 years before they talk about incontinence. It often takes 5 to 10 years before an MS patient is diagnosed with MS. Is there any data known about all of us here, the non-neurological patients, how many time we take before we start talking to a doctor about continence issues?
I've seen, there's a study, I cannot remember the author, so I apologize that I cannot quote. I've seen one study that shows that it takes women an average of 7 years to report any incontinence issues to a healthcare provider, and that same study reported men, it took 14 days. Which I found interesting. So that's the only one that I know of.
Thank God, women, neurological and non-neurological, they're normal. They're all the same, not coming out to discuss their issues.
And that's a big thing with education, educating the patients that there is both help out there, and that just because you may have had the issue prior to the neurologic insult doesn't necessarily mean that it can't be improved now.
So I'm training physios in the Netherlands, the general, manual, sports, midwives, in the whole area, to talk about these issues, and they think it's horribly difficult to talk about peeing and going to the toilet, sexual dysfunction. So they really need to be trained in for that part.
Well, and that's one of the reasons why, too, I found it helpful to come up with those easy questions, because then they, if they don't feel comfortable talking about it, if they ask the patient even just to fill that out on a piece of paper and say, hey, I noticed that you marked yes to some of these questions. Would you be interested in talking to my pelvic floor physio that works here?
That's the same we do. I have the same list like that.
Yeah, absolutely.
If the physio is too scared to talk and get hot flashes of the idea to talk about it, is to give them the form and give me the form, and we correspond on that.
Absolutely.
So thank you very much.
Thank you. Thank you. Any other questions? Well, thank you very much for attending. Don't forget to fill out your evaluations, and thank you.